So today we have the last approach of, you can say, the posterior cranial fossa. Simultaneously, we have covered the posterior cranial fossa, all approaches. Not these approaches are only for the medulla oblongata, but you see that we also covered the all lesions of posterior fossa. Either it is a suboccipital midline, either it is a telovelar approach, either it is a lateral or foracondylar approach. Now it's a transpetrosal approach. The transpetrosal approach is a very good and standard approach for most of the lesions that are very far away from the uh, posterior fossa. You can say at the lesion at the level of petroclival area or brainstem or the lesion away from the petrous part of the temporal bone, posterior fossa, and then we can go for the transpetrosal approach. Either it's a vascular problem, aneurysms are there, either it's a lesion of even the midbrain can be approached through this one, even the bones can be approached through this approach, even the medulla oblongata can be approached, even the petroclival area can be approached through this one. We divide usually the transpetrosal approach into two: one, the anterior transpetrosal approach and the posterior transpetrosal approach. So let's start. So this is the we
Dr.
approach
Itzaz,
the
we have
posterior
lost you.
transpetrosal approach.
We have lost you. I think we should go with the last time's approach. Yeah, we cannot turn the cam on. The internet bandwidth is slow on your side. I
Now it's
think,
okay.
yeah, it's better.
Okay. So our target is this area. Either we are going through with the help of this one. This is the petrous part of the temporal bone. We divide it that how we are going to the anterior petrosal. Uh, this is the the bone that's midway, half midway, anterior petrosal approach. But target will be here actually. If we are going through here at this area, the anterior petrosectomy is excellent. If we are targeting this area, then the posterior petrosectomy is good one. Sometimes, and we do the combined approach that we call the combined means the petrosal plus pre-sigmoid approach. Pre-sigmoid is the modi form of the retrosigmoid. Retrosigmoid usually we do go through below the sigmoid. That's why, and posterior to the sigmoid. That's why we call it a retrosigmoid. But in pre-sigmoid, we go just above the sigmoid area, and then combined with the anterior petrosal approach and the posterior petrosal approach, we call it the combined approach. Okay. If there is an extensive lesion is there, then we can go for this one. But anyways, to do a good surgery, it's very important. You should know the landmarks. It's very important that we should be aware of the normal anatomy. In this one, we should be a good enough in the petrous bone anatomy. Here, this is the petrous bone. Uh, this is the petrous part of the temporal bone. From here, till that here. This hole is the petrous part of the temporal bone. Okay, this. So this is the petrous part of the temporal bone. We should be well aware of all the parts and the structures, important landmarks of this whole bone. When we talk about the petrous part of the temporal bone, it has apex. This is the apex. This is apex. It has base. This posterior area is called the base of the petrous part of the temporal bone. This is the petrous part of the temporal bone. There's apex, there is a base, and it has three borders. This is the superior border that has the ridge. Look at here, this one. This is the superior border. This is the anterior border. And this will be the posterior border. So it has three borders: superior border, anterior border, and the posterior border. Here you can see easily, this is posterior border, this is superior border, and this is the anterior border. So it has three borders, one apex, one base, three borders. It has three surfaces. The surface that is bounded between the superior border and the anterior border, it is the anterior surface. This is anterior surface. The surface that is the area that is bounded between the superior border and the posterior surface. And the third one, there is the third surface. Yes, please. Anyone? So till that here, it is okay. Are you getting?
Yes, sir, it's clear.
Yes, sir.
Why your people are so quiet? Till that it's okay?
Yes, sir. Okay,
So
sir.
where
Yes,
is
sir.
the inferior surface? Anterior surface, posterior surface, and the third surface is there. That is the inferior surface. Okay, this is inferior surface. This is the inferior surface of petrous part of the temporal bone. That is also very important. So how many anatomical areas are there? One is the pegs, one is, so one by one we are going through this one. When we talk
Dr.
about
Taj, your voice keeps breaking. So
now,
we
it's
lost you after the surfaces.
okay. I have completed the surfaces. When you talk about the surfaces, so let's come with the anterior surface. Okay, anterior surface. Anterior surface has a lot of structures inside. Can you see this depression? This one? Yes, I'm not talking about this one. It's visible. Audible?
No, your voice is breaking a lot more than usual. I think you would need to move closer to the router or something. You need to move closer to the Wi-Fi.
I'm very close to the
You're
Wi-Fi.
not audible today.
Now,
I have no idea
I'm
why this
audible.
is happening. Yeah, you are audible now.
Now audible?
Yeah.
Okay. Can you see this depression? This depression is there?
Yes, sir.
Yes. Okay, good. Can you see this depression? What this depression is called? This one? This depression? Yes, anyone?
Operculum of temporal bone.
Operculum of temporal bone. What is the significance of this one?
Sir, before doing the surgery,
Mhm.
we Pre-operatively, we check the thickness of the IPS and the posterior limit of drilling of the IPS as well.
Inferior petrosal sinus.
Sorry, internal auditory canal, sir, IAC. Posterior limit of drilling of IAC and the cortical thickness of the bone overlying the IAC, sir.
But this is not the level of IAC, Dr. Mustafa, internal auditory canal. It is just behind, little bit behind. It is included in the part of the posterior petrous part of the temporal bone, not the anterior
Okay,
part.
sir.
And it is
Okay, sir.
at the level of the posterior surface, not on the anterior surface. This is the
Yes,
anterior
sir.
surface that is forward anteriorly to the middle cranial fossa. This is actually a depression that is called the Meckel cave. This is Meckel cave. What is the Meckel cave? What is Meckel cave?
Sir, this is the area in which contains the cistern in with the trigeminal nerve cistern, sir.
Ganglion is there. Excellent. Okay, good. So this is the area that is called the Meckel cave. It is the depression for the ganglionic depression of the trigeminal nerve. Just after this is elevation. Can you see this elevation?
Yes, sir. Yes, sir.
This is elevation. Okay. And there's also
Yes.
an elevation is here. Okay. What is
Yes, sir.
called
Yes,
it?
sir.
What elevation it? What we call it? This elevation? Yes. This we call it arcuate eminence. This is the
Okay.
arcuate eminence. Meckel cave depression. There is eminence arcuate, the arcuate eminence, and just below to this one, there is a thin bone. This is a thin bone is area here. What is this? This is called the tegmen tympani. Okay, this is a thin bone, very thin bone that we call is the tegmen tympani. So this is the just surface, upper area of the surface. When we go just anterior to this one, what is this structure is there? Yes, please. What is this one? What is this one? This one. This is the foramen lacerum. The foramen lacerum is there. As just we came out here, this area, this will be the area of the internal carotid artery, and just below to this one area, there will be the fossa. Can you see this one, please?
Yes, sir. Yes, sir.
Am I audible?
Yes, sir. Yes, sir. You are audible, sir.
I'm audible. Okay, thank you. So this is the fossa. This is the internal artery, internal carotid artery area. When it comes here, it passes through this area and then goes here. That's why we call it, this area will be called the pittus part of the internal carotid artery. Pittus part of the internal carotid artery. This is the area that we call it. What is this area? Just posterior to the internal carotid artery. That will be also the fossa will be there. Yes, please. Anyone? Again, there is that is a internal jugular vein bulb will be here. Okay, this area just posterior to this one, there will be the internal jugular bulb. When just posterior to this one, we have two foramens that will be here. That is clear here. These two foramens will be here.
Foramen ovale and spinosum.
These are not foramen ovale and spinosum. This is ovale, and this is spinosum. these small areas. This is oval, this is spinosum, this is lacerum, this is rotundum here will be. So what about this one? I am talking about these foramens, small foramens here, just posterior to this one. Here these foramens will be. These foramens will be here, small foramens. These foramens are for two nerves. One will be the lesser petrosal nerve, and second will be yes please, second will be greater petrosal nerve. Greater petrosal nerve is the branch of
Facial nerve.
excellent. Greater petrosal nerve is the branch of facial nerve, and lesser petrosal nerve is the branch of glossopharyngeal nerve, ninth nerve. Okay, this is the area. Two foramens are there at the anterior surface, just posterior to this one. These are called the two foramens, the greater petrosal nerve and the lesser petrosal nerve. The foramen that lead to the foramen oval, that will be the lesser petrosal nerve, and that foramen that is going medially towards the foramen lacerum, that is the greater petrosal nerve. It doesn't mean that the greater petrosal nerve and lesser petrosal nerve, they traverses through the oval and lacerum. This is for to remember this anatomy. Okay, this is the anterior surface of this one. Got it till that here? Any question? Any question? No. So now the posterior surface of I say the petrous part of the temporal bone. This is the posterior surface of the petrous part of the temporal bone. This whole this is the petrous part of the temporal bone. Okay, this whole. It has only two important things. Only two important one. What is this foramen is? Yes. Yes, what is this foramen?
Internal auditory meatus.
And what about this foramen?
Vestibular aqueduct.
Meatus or internal auditory canal, and this is the jugular foramen. So there are two important things are there. So what about this one? Internal acoustic meatus, it traverses through this with the help of this one. It gives the seventh nerve and eighth nerve. And what about the jugular one? What about the jugular foramen? Yes, please.
9, 10.
Jugular foramen. What are the contents of jugular foramen?
9th
Well,
and 10th
Yes.
cranial nerve.
Ninth, 10th cranial. Okay, good. So it contains two important structures. When we talk about the inferior surface, we will talk later on inferior surface. But when we talk about the posterior border is this one that contains very important structure. Anyone who can tell this is posterior border? Posterior border contains very important structure. This one, I made it blue. Yes, please.
Inferior petrosal sinus.
Inferior petrosal sinus, excellent. And the superior border, this is superior border, it also contains one important structure only, that is
Superior petrosal sinus.
superior petrosal sinus. And second attachment of the superior border is of the tentorium cerebelli. Tentorium cerebelli attached here till that here, and it then makes the nose. This will be the free area till that here. They will form the attached part of the tentorium cerebelli. So this is the superior border, this is the posterior border. Now comes to the anterior border. This will be the anterior border. This will, okay. Anterior border is just there is no any special contents over the anterior border is there. Actually, just below there will be the internal carotid artery. Just posterior to this, there will be the internal jugular vein. Bulb will be there, not ganglia. I'm sorry. The bulb will be there, and otherwise there is a free area. There is no one. Just posterior to this one, or you can say the anterior to this one, there is other contents of in relation to this anterior border that is not contents of the anterior border. That will be the content of the middle cranial fossa, like the foramen lacerum, foramen ovale, foramen spinosum. But these are related to the anterior border. So till that here we have completed the anterior border, posterior border, superior border, anterior surface, and the posterior surface. Till that, any question? Any question up to here? No? Are you getting or not getting? Yes, please. Am I audible?
You are perfectly audible. It's just that ever since we have started the brainstem anatomy and approaches, they have all gone super quiet.
It's very simple.
So
This is
this is their normal behavior these days. They would get better once a few sessions go on and they realize it's going to be okay.
okay. It's very normal. It's very easy. This is the superior border. Superior border contains two things, two structures. One is the superior petrosal sinus and the attachment to the other contents of the anterior surface medially and anteriorly the contents of the middle cranial fossa foramen. That is the foramen lacerum, foramen ovale, foramen spinosum. This is the posterior surface. Posterior surface has two important areas. One is the internal acoustic meatus, that is contains the 7th and 8th nerve, and other one is the internal jugular foramen. This is the posterior border. Posterior border has only one important structure, that is the inferior petrosal sinus. And posteriorly at the base of this one, just that forming the floor of the posterior part of the cranial fossa laterally, it has a large fossa here. What is this fossa? Yes, please. What is this fossa?
For sigmoid sinus.
Excellent. This is sigmoid sinus. And what about this one? Sigmoid sinus will be here till that here. What about this one? Yes, please.
Jugular bulb?
What about this one?
Jugular
Jugular
bulb?
bulb. Dr. Kamal took an excellent class yesterday. If you will not tell, you will get punishment. So this is the jugular bulb area. This is the sigmoid sinus. Then there will be the transverse sinus. So this is normal. So our target will be here. Okay, this will be our target. So till that here, any question? No?
No, sir.
No question. This again, the whole petrous part has been separated. This is the whole petrous part of the temporal bone. Very excellent. This is a good view of the jugular sigmoid sinus, then jugular bulb. This is the posterior surface. This is the anterior surface. This is the foramen ovale. This will be the foramen lacerum. The internal carotid artery travels through there from here, and the internal acoustic meatus will be here, and jugular foramen will be here. This is the apex of the petrous part of temporal bone. This is the base of the petrous part of the temporal bone. This is inferior surface of, you can say, the petrous part of the temporal bone. It is very easy to memorize. Look at here. You people will tell me. What is this area? Yes.
Foramen lacerum.
Foramen lacerum. Excellent. What will be this area?
Internal, carotid canal. Carotid canal.
what about this area?
Jugular foramen.
Foramen, this is fossa. Okay. And what about this foramen? What about this foramen? This is the stylomastoid process. And this is the foramen. What we call it?
Hypoglossal canal.
Stylomastoid foramen. Oh, Mustafa, what you're doing? Hypoglossal canal will be here, my dear. This is stylomastoid process. We are far lateral, too lateral at the base. This is stylomastoid fossa. Sorry, process. This is stylomastoid process. That has the notch bilaterally downward. Just posterior to this one, there is a foramen that we call a stylomastoid foramen. What is the content of stylomastoid foramen?
Facial.
Facial nerve. Excellent. So this is the posterior surface. That's excellent. This is the posterior surface that is bit, you can say, the rough surface. It gives some structures that passes through, and it has the lot of attachment for the muscles and ligaments. When we go detail through the lower base, the inferior surface surgical approach, then we will do this one. So now come to the transpetrosal approach. Transpetrosal approach, we are going to the anterior petrosal and posterior petrosal are combined entry petrosal plus the pre-sigmoid approach. This is the skin incision. Sometimes that is the question mark incision, just anterior to the superior to the at the level of pinna anteriorly. Just go behind and retrosigmoid area. This is one incision. Another incision that is given like this one, when you are typically going only for the anterior petrosal approach or transpetrosal approach, we can go give only this incision as well. That is this incision. Just 1 centimeter anterior to tragus, go upward, tell the superior temporal line, then go back at the level of just behind to the mastoid area of this one. This is the anterior part of this one. This is the posterior part of anatomical posterior part. So we have given the incision after taking the flap, that is the temporal muscle anteriorly will be there, and posteriorly we have the posterior side muscle will be there. So we'll take off the all muscles. Then we have to know the landmarks. Different landmarks are very important, that because sometimes we have to do the mastoidectomy when you are typically going for the posterior petrous approach. That landmark is the posterior end of the zygomatic arch. This is the posterior end of the zygomatic process, and this is the mastoid area and the tip of the mastoid. This is the whole the mastoid, and this is the zygomatic, because later on we have to take this whole bone, otherwise it will be very difficult for us. After getting all the muscles, this will be whole our cranectomy, or this will be whole our craniotomy. This is one piece craniotomy, one bar superior to the transverse sinus and one bar inferior to the transverse sinus at the level of the posterior fossa, at the level of the temporal bone. Then we will cut this whole bone and in one piece, beside not this one only, because later on for the mastoidectomy we will do this one. So this is the craniotomy that we have done in one piece. This is the level that I told you that for the mastoidectomy you have to know the landmarks. This is the landmark, that is zygomatic, posterior part of the zygomatic area, zygomatic process. This is the mastoid tip, this is the mastoid bone, and here with the asterion till that here you have to cut this whole bone, one piece, but superficial cut down. Where we have to stop till that here, when we are seeing the mastoid cells. You have to, with the help of drill, you have to cut down the bone, then the mastoid cells are there, then we have to stop here. Why stop? Because we have to see the three structures here, and we have to see that if there is any CSF leakage or not. When we will do this, actually we have to come at the level of this area. After the drilling the mastoid, we will drill this mastoid air cells very humbly and very gently. We have to drill this mastoid air cells because they are very delicate structures are there. So after drilling this one, this will be the picture of this one that have the content the mastoid antrum, and there are circular canals. You have to see the three semicircular canals, that are the posterior semicircular canals, that are lateral semicircular canals, and that is the superior semicircular canals. So this will be the picture of this one. This is the thin bone over area here. Later on we have to cut this one because this is the area where there will be sigmoid sinus. You have to be careful about that. So when you will cut down this one, you have to memorize one thing. Then when there is a area that is here, this is the lateral semicircular canal, and this will be the superior semicircular canal, and here will be the posterior semicircular canal. Posterior semicircular canal towards the temporal lobe, superior semicircular canal towards the posterior fossa or the cerebellum, and lateral semicircular canal, that will be the outward. That we have to see, and these are all structures. Okay, and this bone that is over the sigmoid sinus, you have to cut through it, not break this one. Cut with the help of not the drill. Try to this cut the bone with the help of the bone nibbler. That should be very easy, and easy bone is there. We can cut it easily.
No, I think there is an interruption on his side, and that is why he has muted himself. Let's wait for a few seconds and see if he's with us. Dr. Itzaz?
Sure. Yes, sorry.
Oh, that's okay. You can
There
continue.
was-
I'm muting myself.
Okay, sorry, there was some emergency surgical case. My case was there, so I delayed that case. That's why, because it has a little bit late time. So you have to cut down this bone, that is the sigmoid sinus, then that will be visualized. Why? Because we have to see whole the bone, cut down whole the bone. We have to visualize whole the sigmoid sinus till the jugular bulb, because later on we can mobilize that one. Okay, when we cut down, this will be the picture, and already we have seen that one. That is the another picture of the another patient. That is the posterior part. This is the anterior part of this one. This is the sigmoid sinus. We have to see that one. This is the bones. We have cut down all the bones over there. Uh, we can see the all. This is the labyrinthine. We can see the seventh nerve traverses here. All the semicircular canals, that is not visualized here, but these will be here. Okay. Okay, then when we when we have go through, where is the previous slide? Yes, please. When we have cut down all this one, and this jugular bulb, sigmoid sinus, this temporal lobe, the posterior fossa visualized, one thing that we have to do with the help of periosteum, when doing this one, we have to peel the dura. We have to retract the dura from the temporal side. When we retract the dura from the temporal side, it will be flexible and give some space intraoperatively. So first steps after doing this procedure, it is just to peel the dura at the level of the temporal lobe area. But be careful about the sigmoid sinus. Okay, don't give any retraction over there. Otherwise, uh, for us to handle it. Not handle it, just bleeding will be there and field will be not good. So retract the periosteally detach the dura from the temporal lobe. It will give, we can cut this dura fossa. Why we are giving two cuts? Yes, please. Two small nicks of the dura that we call the durotomy. Yes, please. Why?
Your voice is breaking
Just
again.
two nicks. Now it is clear.
Dr. Itzaz, yeah, it's better now. If what you said in the last minute, you would have to repeat because it was lost.
I said that after giving this retraction, a periosteal detachment from the dura from the temporal lobe, we have to give two nicks. One is the anterior at the level of the temporal lobe, and one at the posterior, just posterior to the sigmoid sinus. Why? Yes, please, anyone? Yes, please, anyone?
Sir, to avoid sudden decompression.
To avoid sudden decompression. So what will be there if we give two cuts are there and the dura?
Superior and inferior petrosal
We want to
sinuses.
decompress. One. Sorry?
So to
Yes, what
expose
are
the
you saying, Dr. Meher?
To avoid damage to superior and inferior petrosal sinuses.
To drain the no, that is far away. Just to drain little bit CSF. Just to drain the CSF.
Okay.
Just to drain of CSF. Some part. Well, go to dura, the CSF will come out, your feed will intradural. Exposure will be more. So after that, when you're cutting the dura, then combine this one. There will be two cuts. One at the level of this one, that is the sigmoid area that we call it at the parallel to the sigmoid here. Another cut in the temporal lobe cut will be there because we are exposing bilaterally at the side of the temporal and the posterior fossa. Okay. Here. These are two cuts. Okay. Look at this one. At the level of the temporal lobe. This one, these two cuts are here. This is the dura at the posterior fossa. This one.
No, we can't. I think there is an interruption on his side. Let's wait for a minute.
So this is the posterior fossa, and this is the dura, that is the temporal lobe. We are giving two cuts at the both sides, just to communication through both area at the level of the posterior fossa, beside the sigmoid sinus, and at the level of temporal lobe, just pre-sigmoid area. So these cuts are simultaneously bilaterally equally. After getting this one, when we have cut it down, the dura, this is the area of the temporal lobe, and this is the that's the area of the semicircular canals. What I was telling you that this is the, well, it is at the level of the temporal side. So this will be the posterior semicircular canal. This is the at the level of posterior fossa, passing towards the posterior fossa are the cerebellum. So this will be the superior semicircular canal, and this will be the lateral semicircular canal. So, okay, when you cut this dura, so look at here. So we have to trace this one area. There are two traces are there. What we have to see after cutting down the dura, both levels, we have to approach the base of the petrous part of the temporal bone, and we have to see the tent of this one. So this is the tent actually. Look at here. Okay, getting? Are you getting?
Yes, sir. Yes, sir.
So this is the tent of this one. Okay, why are you pressing this tent? Because this tent it contains the superior petrosal sinus. So what we have to do first, we have to ligate this superior petrosal sinus. When we ligate this petrosal sinus, after ligating this superior petrosal sinus, we have to coagulate it. Okay, we have to coagulate it. When we will coagulate this one, how will give incision to the tent? Yes, please. Anyone?
Sir,
So this is the tent.
perpendicular to the superior sinus. Sir, parallel to the transverse sinus and perpendicular to the superior petrosal sinus.
Very good. Okay, we have to give the incision till that.
Till the insertion of the vein of Lappe into the tentorium, sir. Into the sigmoid sinus, sir. Transverse sinus, sorry, sir. Transverse sinus.
You are very clever, Dr. Mustafa. So you will be a good surgeon and good academician as well.
Thank you.
So you have seen all the structures in front of this one. That's why you are saying, I think that's good. Okay, you are right. This is the anterior temporal basilar vein. This is the middle temporal basilar vein, and this is the vein of Lappe. You have to be very clear when you are addressing the temporal lobe. So you have to cut down the tent till that. Okay, we have to be careful about this structure vertically. But this tent, you have to give the incision till that the all going down till that the insertion is there, till that there is attached part is there. Okay, because you have to approach the anterior petrosal area, because this tent at the anterior petrosal area, this tent is deficient. Till that one, it is attached over the superior border of the petrosal, superior border of the petrous part of the temporal bone. That's why you have to cut down. When you will cut down, then this is another picture, same picture that we have given the incision at this area, and we have get access to the posterior part of this one, that is the cerebellar area, and that is the durameter of the posterior fossa that we have cut down this one. So this is the temporal part of this one, and this is the posterior cranial fossa. Our concern is the posterior cranial fossa. If we are going through this one, and this is the cerebellum. Cerebellar is the petrosal surface of the cerebellum. So again, this is the anterior cerebellum surface superiorly towards the tent. These both surfaces will be visualized when you will see the at the level of you can say the temporal area. You have to see three veins importantly, that is the middle anterior vein of Lappe, and posteriorly at the level of occipital there will be the occipital vein. So when you are getting through this one, all structures, we have cut down the tent, we have cut down the dura of the posterior cranial fossa, we have cut down the dura of the middle cranial fossa, the temporal lobe, all structure that will be visualized. So you have to know that what we are doing this one. If your target is anterior petrosectomy, so you have to go through the Kawase approach. That is the Kawase. That we call it the Kawase approach. What is the Kawase approach? What is the landmarks of Kawase approach? Yes, please. Yes. Anyone? Yes, please. Anyone? So when you are going through this one, this is the zone of Kawase. This is the zone of Kawase. That is in between the 7th and 8th nerve will be there. So this is actually the zone of Kawase. When you will go previously at the level of, you can say the base of the skull, that will be the greater petrosal nerve, and later on there will be the petrous part of the temporal bone, and the posteriorly there will be the internal internal carotid artery landmark will be there. With the help of that one, you will enter. And here, when you will reach here at the level of intradural area, so this will be the area that is the direct approach, this one. Anterior petrosectomy, you will do. Anterior part of the petrous bone, just before the apex, we have to drill that one. Why we have to drill? Because the posterior canal fossa a little bit downward as compared to the middle canal fossa, as compared to the anterior canal fossa. So we cannot visualize the structures without drilling the anterior petrous part of the temporal bone. When you are approaching this one, anterior petrosectomy, with the help of Kawase, you will enter, that is the 7th, 8th nerve. Then will go downward. You will see the posterior canals if we are approaching the medulla. Why? Because this is the area, you can see this is the clivus. Okay, so this is the clivus. Our target will be here. So with the help of this one, we can approach the anterior petrosectomy. If the lesion is just above, so we will approach the Kawase. If this lesion is just go down, we have to go down. If lesion is at the level of medulla, so what will be our targeted area? Yes, please. If the lesion is at the level of medulla, what will be our target? Yes. This is another view of whole view, that we have cut down all structures, and we are seeing the level of brainstem hole, the lower cranial nerves, that is the 7th, 8th complex, that's the 5th nerve and the 4th nerve. So our target will be, when we are approaching the medulla oblongata, our target will be lower cranial nerves. Am I right?
Yes, sir.
Are you
Yes, sir. Yes, sir.
When some point is difficult to understand, just tell me, I have to repeat that one. So if we are targeting at the level of medulla oblongata and the level of lower cranial nerves, what will be the safe zones at the lower cranial nerves to the medulla? Yes.
Sir, anterior lateral sulcus and posterior lateral sulcus.
Okay, how we will enter through it? Now tell me.
Sir, Vagos accessory triangle.
Excellent. Why are you then confused? There is only one triangle that we have to enter through, that one. That you have to address, you have to see the triangle. That is the vagoaccessory triangle. You have to enter through that triangle. Okay. You have to enter through right triangle. That is again the above lower one. That is 9th nerve, that is 10th nerve, and the below one. This is the 11th cranial nerve. And in between these two triangles, you have to approach through the so look at this one. This is the pica. With the help of this one, here will be a triangle, and the 12th nerve is just here. So you have to make this trajectory with the help of this one, and you have to approach the medulla oblongata. This is same. We have seen the lower cranial nerves here, and we have to see that where is the triangle is there. Then we have to enter and address the medulla oblongata. Here we will address at the level of midbrain. Here we will address at the level of the bone. So see, this approach is why standard so good, that simultaneously you can address all the brain stem from the midbrain to the medulla oblongata lesions. Anyone, any question about today's class?
Thank you, sir. Thank you, sir. Wonderful. Thanks.
I think you you're not getting, you didn't get in today's class. So am I right?
No, sir. This is very beneficial class. Thank you, sir. Thank you for your precious time, sir.
It's a bit difficult. So I will try to repeat this one tomorrow again because it is a bit difficult and
Okay, Dr. Sana is owning.
difficult to get.
Yeah, Dr. Sana is finally owning that yes, it is difficult. We would appreciate it if you all can own up that this is difficult and you would want a review session. Dr. Itzas, can we divide this in the anterior petrosal, then the posterior petrosal, and the combined petrosal approaches? Because this is the last session of this week. The sessions now start on Sunday, and Sunday probably around 2 p.m. But let's see, we can discuss that after this session. So would this be okay
No,
if you can cover this in two different sessions?
yes,
Because they have
two
some
different
idea on the
sessions.
anatomy.
Two
Yeah.
different sessions. I think uh, now if the Petrus temporal bone anatomy has been cleared for them, then it will be very good and easy to understand the landmarks. So if not clear, just put a message that we are not cleared about this Petrus part of the temporal bone anatomy or the approach, that how we have to approach. So we have to give a concentration over that point, for that area. Because if the Petrus part anatomy is not clear, then any approach is will be not cleared. Okay, either it is the anterior petrosal, it's the perisigmoid, or the posterior petrosal. It's all about the petrous part of the temporal bone. I think that we have to revise this class again, this whole class. So they will most probably they have got something about little bit idea about the petrous part and the structures what could be there. But when we'll review this class again, it will be cleared. So it's up to you or up to them. If they are saying that
What
we
we
have
can
to
do
step.
is, okay, what we can do is, I think I can do a structured or a brief review of the petrosal bone anatomy and the vasculature and associated structures, whatever it is. So I can do the anatomy session so that you know you are not getting overburdened, and then you can take two different classes, one with the anterior petrosal approach, the second one with the posterior petrosal approach, and whichever finishes first, you can just throw in the combined petrosal approach as well. I think that would be
Okay,
better for retention. Otherwise, they would probably not remember anything that we are teaching.
okay, it's good. But there is some I feel some difficulty if you are taking the Petrus bone and then I have to talk this one because
Okay.
I make orientation according to anatomy. If
Okay.
I cover the
Okay, that's fine. Then you can just take two sessions.
okay,
The
no matter.
anterior, you can review the anatomy briefly, and then you can do the anterior approach on that day, and then you can do the posterior approach and the
Posterior approach
combined approach
also.
on the second session.
Okay,
Does that work
that would
better?
be that's yes, that's better.
Okay, okay, everyone. So if you have any questions, any feedback, anything that you would want to discuss regarding these approaches, you can always leave a message on the group. And uh, because we understand that these are not typical approaches, and they are harder to understand, harder to retain as well. And what we want is for you to retain everything. So please leave some feedback or any messages, any questions. Otherwise, this is a wrap for today's session. Thank you so much for joining. Thank you, Dr. Itzas, for taking out your time.
Thank you so much.